Hi everybody, I'm Seth Truger, digital media editor for JAMA Network Open.
And I'm Mike Berkowitz. I'm electronic editor for JAMA and the JAMA Network.
So welcome to this episode of JAMA Network Live. We're going to talk about 3 of the papers that came out in this week's release of JAMA Network Open. If you're following online live, be sure to comment or submit your questions on our just comment under the Facebook post or respond to one of the tweets at JAMA Network Open.
And if you're interested, be sure to follow us on JAMANetworkOpen.com to check out the articles that we're going to discuss.
Okay, so first up, we've got a study, a U.S. national study of the association between income and ambulance response time in cardiac arrest by Renee Shaw and colleagues.
And that sounds like a mouthful, Seth. Can you tell us in common language what they looked at?
Sure. So they looked at people with cardiac arrests in the field and tried to see if there was a connection between how long it took ambulances to come see them, treat them, and take them to the hospital by income of the zip code they lived in.
Oh, that's interesting. And so what's the sampling frame? Is it the continental United States, and is it lots of years or just a single year?
So they use the NEMSIS database, which is a pre-hospital database that 46 different states send info to. It covers about 2,500 of the 3,000 or so counties. So it's most of the pre-hospital calls in America, and they looked at all the data from 2014.
Great. And, you know, income by zip code, we know zip codes take these unusual shapes and contain lots of different neighborhoods. Do we know anything from this paper or from your knowledge as a researcher about how accurate that is in terms of classifying or clarifying the income of the neighborhoods?
Yeah, so overall zip codes can vary a lot in size and characteristics, but in general there's so many zip codes, and when you're looking at a lot like this, it's a pretty decent way to look at, big areas spread out in the country by as a whole.
Great.
Compare different areas and a lot of different confounding that's all entangled with each other.
Good to know. So tell us more.
Yeah.
What did they look at and what did they find?
Sure. So they divided the zip code by income quartile, so the poorest quarter of people and the wealthiest quarter of zip codes, and looked at what the ambulance response times were. And not surprisingly, they found that people in poorer areas had longer response times, and basically it took longer for the ambulances to get to them in the first place. It took longer for the people in the ambulance to treat them all over the field, and it took longer to transfer them back to the hospitals.
So that at face value seems like it's not a good thing for people living in poor neighborhoods. Do you agree with that?
In general, yes. Obviously, there's a lot of things that it's hard to know about, but basically their main conclusions, and when they were analyzing the data, was that people in poorer neighborhoods needed to be transported farther to get to hospitals, and we know that the longer delays somebody has to care in cardiac arrest, the worse they do. The authors cite a paper that says about a 17% increased chance of mortality for every minute in delay in cardiac arrest treatment.
So that's interesting, but I had a couple reactions. There's a line in there that's not really prominent that says there were more EMS activations in the higher income neighborhoods, and that led me to wonder whether the EM technicians actually know the neighborhoods a little bit better and had more experience finding addresses. So it may not be, it may be a disparity in access to care, but it may just be experience of the emergency system. And then, as you note, they kind of disaggregate total response times into response times, the amount of time it took ambulances to arrive on the scene, the amount of time they spent with patients, and the transport time. And it seemed to me that if they're spending more time with patients, taking care of them, there may be something going on there. That might be actually a good thing, or the patients in lower income neighborhoods may have more severe disease or may have been down longer. I wonder what your impressions are in response to those observations.
Sure. There's a lot of different things, and as you said, that data that you summarize is, the data you just talked about is summarized graphically in figure 1, which kind of shows the split and how each gap gets a bit bigger. There's a lot of different things that could be going on. We generally know that patients who are poorer tend to have more comorbidities. They tend to be sicker. They might be judged by the EMTs to need things like advanced airways, which take more time. But we also have really mixed data and don't really know if doing more interventions pre-hospital are actually better for patients in cardiac arrest or not.
Right, and that's what I was going to ask you. You're an emergency medicine physician, and do you have any sense of this in kind of the trenches in terms of taking care of these patients who come through the ER doors as an emergency, whether this makes much of a difference?
It certainly seems to. The data certainly seems to indicate that people who get faster care in cardiac arrest are more likely to get their circulation back and more likely to have neurologically important outcomes when they get out of the hospital.
Okay, I think that's ROSC, return of spontaneous circulation, right?
Return of spontaneous circulation, and more importantly, return of neurologic function, which is what we really care about.
Okay, very interesting. What do you have up next?
Okay, so the next paper we're going to talk about is really intriguing. It's the prevalence of and risk factors associated with patient non-disclosure of medically relevant information to clinicians by Dr. Levy et al.
Non-disclosure of medically relevant information to clinicians. So that means my patients may not be telling me everything that I need to know to take care of them.
Right, absolutely. And so basically what they're looking at is, are patients either withholding information from physicians when we talk to them, or are they lying to us about what they're telling us?
Lying. Does the paper use the word lying?
I don't think so. That's probably me.
Okay.
And I'm generally a softie, and I generally think most of the time patients have, there's reasonable barriers, there's different social cues and settings and all sorts of power imbalances, and patients aren't just bad people who don't want me to help them.
Right, and I think another aspect of this is whether patients aren't disclosing things because the visit is rushed and physicians aren't asking, or whether the physician is actually asking and trying to get the information out, and the patient is withholding the information in some way.
Right.
So I assume that this is focusing on that latter example.
Right, exactly. And the two interesting things they do is, first they look at what sort of information is being withheld, and it's summarized in table 1 here.
Okay.
And a lot of it is things where I was actually surprised how high some of these rates are, that basically over a third of patients are disagreeing with the clinician's recommendation.
Okay.
And a lot, about a quarter or a third of what they found are patients who don't understand the instructions that we're giving them, and they're not telling us that they don't understand that.
Right. So that wouldn't be the first time that we all have experiences where somebody's giving us information pretty rapidly and we're nodding and saying yes when we're actually just trying to understand what's going on. That's a pretty human response, right?
Exactly. And I think we all have this experience as clinicians where we're busy, we forget how much specialized knowledge we have, and we forget that patients don't always speak our language, and it's not always easy for us to give patients the opportunities to clarify, or even not, on a busy day, it's hard for me to control my facial cues, and it seems like I could be judging patients even if I'm just trying to explain.
Right, wonderful. So that's kind of the structure of kind of the questions. What are the actual findings? Is there more to learn from this?
Sure. Well, if you in table 2, it looks through some of the motivations patients had for why they were withholding information, and it's really interesting. Something about 70% of them said they just don't want to be judged about their behavior, or another big chunk were just didn't want to be embarrassed because they know they don't exercise or eat healthy enough. And a lot of it is patients don't want to hear how bad the behavior is for them. People know that smoking's bad for them. That's not a surprise. People know you're supposed to eat healthier than most of us do.
Right, and we have our first comment from Ketamine H says, how do you know that they didn't lie to the investigators? We don't obviously know that they didn't lie, but it's kind of assuming the worst on the patient's behalf, and most of our clinical encounters, really everybody's coming to the table trying to communicate or doing their best to communicate.
Yeah, but thanks for the question, man.
Great, and so is there anything else in this?
This one, I don't know, I think we covered the meat of this one pretty well.
Well, so I just want to make one point,
Go ahead.
because I'm kind of a primary care geek, and I think the survey question has this ever happened to you with any clinician?
Right.
And that's a pretty sensitive kind of frame for the question, but it's not particularly specific, right? So if I'm rushing in and talking to a nurse or something like that, I may forget to say something. I'm kind of making up that example, but it doesn't take into account the trust and that develops between a patient and a clinician over time in a primary care setting. So that's not your issue in the emergency room where you see patients once or multiple times but don't develop relationships. But I imagine that the ever question really jacks up these numbers because people who have relationships with physicians presumably over time grow to trust them. And that issue of trust becomes very important in terms of the transfer of information.
Right, and also kind of statistically, a lot of these numbers are going to look bigger on their face because 80% of people might have one time not understood something. That doesn't mean that our patients are withholding information 80% of the time.
Right. And I had a patient who was kind of somewhere in the middle. He was a patient with type 2 diabetes, and he was pretty non-adherent. And he wouldn't admit it to me, but I would say, did you take your medicine? And he'd say, I'm not going to lie to you, doc. I'm not going to lie to you. But he would never say that he was or wasn't taking it. But I knew what our situation was. But I didn't give up on him, and we had a great relationship, and we kind of took him as far forward as we could.
Right, and the good thing is in a lot of situations like that, patients are still getting the information. If we're asking them about taking their medications or about eating healthy foods, they know what they're supposed to be doing. And just, unfortunately, there's a lot of barriers.
Right, and our recommendations are based on what we think is in their interest. We can't force them to adhere, and there are other patients who want to follow some recommendations and not others. So in some respect, we need to meet patients where they are in terms of their priorities. I had a patient who was only interested in her blood pressure and didn't care that over multiple visits she had blood in her urine. She didn't care whether she had a renal or a bladder cancer. All she wanted was her blood pressure numbers to look good. And I just worked with her on that over a number of years. All right, great. What do you have up next?
Great. So the last paper we're going to talk about is the prevalence of elective and ruptured abdominal aortic aneurysm repairs by age and sex from 2003 to 2016 in Ontario, Canada by Dr. Salata and colleagues.
AAA, and that's not the American Automobile Association, right?
No, it is definitely not, and it's definitely worse for you.
Tell me about AAAs in Ontario, Canada.
Great. So what this team did was look at all of the different AAA repairs that happened in Ontario between 2013 and 2016, about 20,000 in all, about 2/3 of which were open and about 7,000 were endovascular or EVARs, which are becoming more and more popular. And most of them were scheduled. Only 2,700 of them in the study were ruptured AAAs.
I see. Okay, so this seems, I think, straight surgical epidemiology, bread and butter. I wasn't sure, did they have a research question that they're trying to answer, or is it just characterizing kind of the health services aspect of this?
Right. Well, I think the main question is how is our treatment of AAA changing over time, and in what subpopulations? They looked at a few different types of populations, mostly by age. They divided into quintiles of age, and they found, interestingly, that patients over 79 are getting more elective AAA repairs, and most of the increase is from endovascular repairs.
Right, and I think the point there is that with open surgical repairs, these older patients with AAAs were judged to be too high an operative risk, but now that we have the minimally invasive or endovascular interventions, there are now candidates for surgery.
Right, exactly. And so they're able to do more preventative AAA repairs by just putting stents in endovascularly instead of opening people up and doing this big surgery in the back of your belly.
And do we know from this paper or any of the other literature, which you may not be familiar with, whether that's making a difference for this age group of patients? Is treating their AAAs making any difference in outcomes?
So this paper doesn't answer that question specifically because they're only looking at the procedures that actually happened and not long-term outcomes, and it's certainly not randomized. But they did certainly find a lower and decreasing rate of rupture repairs. So they found that there's more preventative AAA repairs, but fewer repairs of rupture.
Was there any cohort aspect of this so that they could see patients who had endovascular repairs and then follow them up to make sure that those same patients weren't having open ruptures? Or we don't know, but these could be dependent or independent patients?
Yeah, I'm pretty sure they're independent. I don't think they linked them in this database in this study.
Okay, and you and I had an offline or a sidebar conversation about who's doing these procedures. Because we know it's vascular surgeons, but you had thought maybe in some institutions cardiologists are doing it, interventional radiologists are doing it. Do you have anything to say about that? And do you guys know out there who's doing it in your institutions? If you want to tell us, please send us comments.
Sure. Yeah, I think from what I've seen, it's mostly done by vascular surgeons, but with EVAR as an endovascular technique, it seems to be done by interventional cardiologists and interventional radiologists as well.
Is that right? Okay.
And I've certainly heard of some chest surgeons who do it as well.
And I think there was another point here that I pulled out, you're saying that reminded me, is that there's a growth in the number of these operations in women, if I understand correctly. So we think of this as a man's disease, and it still is predominantly. If I read these data correctly, about 80% of these procedures are happening in men compared to women, both ruptured and elective, both minimally invasive as well as open surgical. But apparently, and I didn't know this, there was an issue with the actual, the endografts were designed for men.
Right.
They weren't the proper patency, and the delivery devices were designed for men. So women didn't have the opportunity to have these minimally invasive procedures, and this documents a slow creep towards development of the technology that allows women to have the minimally invasive or endovascular repairs. Is that your understanding also?
Yeah, that's correct. Again, I'm not an expert on AAA repairs as a simple ER doctor, but they did comment that they are getting that, that not only do women have smaller anatomy than men do, especially in the vasculature, in the femoral and iliac vessels, but that the newer stent grafts are actually smaller, so they're able to place smaller ones in women, and it seems to be decreasing that disparity in treatment options a bit.
Great, and because you've identified yourself as a simple ER doctor, just tell me about what you see in AAAs in your institution, in your practice. Now, Seth is at Northwestern University. That doesn't represent any other health center but the one he's in, but I'm just interested in what's going on clinically these days.
Right. What we see with ruptures tends to be more EVARs, and even in the patients the post-op patients or the patients who I've seen who remotely had repairs, most of them are done endovascularly that I see in my experience.
And are the ruptures dramatic ruptures, or are they kind of small leaks with back pain, and you kind of can document or diagnose through imaging that there's these small leaks and they have the time to go there?
Right. Well, it's still a mix, and unfortunately, a lot of the big dramatic ones, we just don't have time to get them fixed. There's just not a lot of time. It's just a big, terrible disease that happens really acutely, and some of the leaks we're able to get to the OR faster and and the vascular teams are able to get the stents put in.
Okay, saving lives as always, this guy on my right. All right, so is that what we have for today?
Yeah, great. Those are the papers we're going to talk about. So be sure to go to JAMANetworkOpen.com to check out the rest of the papers from this release, and be sure to follow us on Facebook, Twitter, and LinkedIn at JAMA Network Open.
Great. Thanks for watching. Thanks for sending comments. And our new releases come out every Friday at 10 a.m. Central Time in the United States. So be sure, if you want to get a rush on the new material, come back and visit JAMANetworkOpen.com at that time, and we'll see you, I think, next Monday, right?
Absolutely.
We'll be here. Thanks, guys. Take care.